In chapter 25, you're going to be learning about the mechanisms of urine formation, which are shown in this figure. The first step is glomerular filtration, which takes place in the glomerular capsule. In this process, the blood is filtered. Everything that is filtered out of the blood is referred to as the filtrate. So glomerular filtration leads to the formation of filtrate. The next step is reabsorption, which takes place along the length of the renal tubule. You may want to go back and review the anatomy of, you're looking at the nephron here. Reabsorption reclaims or returns necessary substances to the blood. And then the third step is secretion, which is basically reabsorption in reverse. So excess substances are secreted into the filtrate, and then some anatomists, physiologists consider there to be a fourth step in this process, which is the excretion of urine, the elimination of urine from the body. Let's look more closely at filtration, the first step in urine formation. You know that blood consists mostly of water. So now we're looking inside the glomerulus, which is the capillary of the kidneys. The plasma is mostly water, but there is some glucose, amino acids, sodium, and other solutes, electrolytes. We also have albumin. Remember, this is a plasma protein that maintains osmotic pressure. It helps to keep the water in the blood. And, there are cells. The albumin and the red blood cells are too large to be filtered out. They won't fit through these pores in the capillaries. Everything else, the water, the glucose, is filtered out and becomes part of the filtrate. So I'm going to abbreviate amino acids, sodium. All of these are filtered out of the blood and end up in the first part of the nephron, which is the glomerular capsule. The capsule encloses the glomerulus. And then this first part of the renal tubule adjacent to the capsule is the proximal convoluted tubule, or PCT, where most reabsorption occurs. Various substances like sodium are reabsorbed. You have the secretion of hydrogen ions, potassium into the proximal convoluted tubule. You should know that sodium drives the reabsorption of other substances. So when Sodium is reabsorbed. You know that water follows. This establishes a concentration gradient of these other solutes, and then they're going to move passively down their concentration gradients. Another key concept you should understand is that the filtrate has the same composition as the blood, with two important exceptions. And those are the large, non-diffusible plasma proteins, such as albumin, and the red blood cells and other formed elements. This is figure 2517. You can see, if you look at the key or legend down below, all of the blue arrows represent reabsorption, the green represent secretion. So you can see which substances are reabsorbed or secreted from various regions of the tubule. Table 25.2 shows which substances are reabsorbed from different segments or regions of the tubule and the mechanism by which they're reabsorbed, which you don't necessarily need to know the mechanism, but if asked, you can refer to this figure, or this table rather. The net filtration pressure is the next concept. You have the formula here and normal pressures. So I just want to explain this in a little bit more detail. Your net filtration pressure can be calculated by the hydrostatic pressure of GC, stands for glomerular capsule. It's opposed by two forces: the hydrostatic pressure of the capsular space and the osmotic pressure of the glomerular capsule. I'm going to do these two in a different color just to illustrate the opposition that the hydrostatic pressure of the capsular space and osmotic pressure of the glomerular capsule have on the hydrostatic pressure of the glomerular capsule. This pressure is the outward force, so it's going to favor filtration. You subtract from that the sum of the other two forces, which are often referred to as inward forces. As long as the net filtration pressure is positive, it's normally 10 millimeters of mercury. That indicates that filtration and urine formation will occur. Again, that's if the net filtration pressure is a positive pressure. I want to look at some factors that can affect these various pressures. High blood pressure can affect the hydrostatic pressure of the glomerular capsule. The osmotic pressure of the glomerular capsule can be affected by high levels of protein. The hydrostatic pressure of the capsular space can be affected if there are kidney stones present. Hydronephrosis is when you have a backup of urine in the kidneys, causing them to swell. So this hydrostatic pressure of the capsular space is a back pressure that opposes filtration and urine formation. And if those are high, if this pressure is high, abbreviate, then you would expect urine output to decrease. The glomerular filtration rate is just what it sounds like. It's the rate at which filtrate is formed in the glomerulus. It's abbreviated GFR. This is defined as the volume of filtrate formed per unit time. Glomerular filtration rate is used to stage kidney disease. It's normally about 120 to 125 milliliters per minute. This table has a summary of the regulation of the glomerular filtration rate. So I want to talk just a little bit about a couple of these intrinsic mechanisms. Intrinsic meaning they're internal to the kidneys. This myogenic mechanism occurs in response to the degree of stretch on the afferent arteriole, which feeds into the glomerulus. And then the second extrinsic mechanism is this tubulo-glomerular feedback mechanism. These are both, again, intrinsic mechanisms. So they serve to keep the glomerular filtration rate constant despite fluctuations in the blood pressure. And you can see that looking at this table again, the purpose of these mechanisms is to maintain the glomerular filtration rate. The myogenic mechanism I mentioned monitors the degree of stretch. Sorry, I couldn't find my pen, which is related to the blood flow. Let me back up for just a minute. Notice that there's a direct relationship between blood pressure and mean arterial pressure or systemic blood pressure. The net filtration pressure and glomerular filtration rate are also proportionate to these other two pressures. So if blood pressure decreases, your mean arterial pressure will decrease. This decreases the net filtration pressure, which decreases the glomerular filtration rate, and vice versa. If blood pressure increases, all of these other pressures or forces are going to increase as well. So if we look at the afferent arteriole and the size of that afferent arteriole, normal diameter shown here in the center, Normally, if blood pressure decreases, we would expect the blood vessel to constrict in order to return the blood pressure to normal range to bring it back up. But in the kidneys, we're more concerned with blood flow and less concerned about the blood pressure. I don't feel like I'm doing this very good. I'm not explaining this very well. Let me try again. I'm going to add a little note up here. So one thing to note, if blood pressure decreases, based on what we just said about the relationship between blood pressure, mean arterial pressure, net filtration pressure, and glomerular filtration rate, we would expect the glomerular filtration rate to decrease. If this is the case, then substances that are normally excreted by the kidneys are going to be reabsorbed instead. Because our glomerular filtration rate is so low, the urine is basically sitting in the tubules. On the other hand, if GFR is too high, then those necessary substances don't have time to be reabsorbed. And they're going to be lost in the urine. Hopefully that makes sense. It's lost in the urine if the glomerular filtration rate is too high, because the filtrate is moving through the tubule too quickly. So if the blood pressure is too high, again, in other areas of the body, we would expect the blood vessels to dilate, which reduces the resistance. But in the kidneys, we're going to get vasoconstriction of that afferent arteriole, which will decrease blood flow into the kidneys. On the other hand, if the blood pressure is too low, we want to open that tubule up wide. Dilation, or open the arteriole, excuse me. Dilation then will increase blood flow, which will bring the glomerular filtration rate back up. The tubuloglomerular mechanism monitors the amount of sodium chloride that's in the filtrate. If levels are too high, same thing, the afferent arteriole is going to constrict, reducing blood flow into the kidneys. And if the levels are too low, that afferent arteriole is going to open up wide. So you can see, referring back to this figure 2514, that in response to a decrease in systemic blood pressure, both the myogenic and tubuloglomerular mechanisms are going to result in vasodilation of that afferent arteriole to bring the glomerular filtration rate back up. In green is the renin-angiotensin mechanism, which is explained in another figure. Hopefully this helps with a couple of the key concepts in chapter 25. Are you sure?